All right, so I was going to show a case of one-handed reverse cart, but I thought that's a CTO joke. I thought I'd show a case that actually was maybe a little bit more on the fun side. So perhaps this may not stand as one of the more challenging cases, but I think kind of an interesting case. This was probably one of my first 5 or 10 interventions when I started my job last year. And you're sort of cath lab doc of the day, you're running around in the morning, this is your first outpatient setup for cath, and then you get hit with a little bit of a surprise. So this is a 66-year-old Caucasian female, history of hypertension, hyperlipidemia, hypothyroidism, remote history of smoking. She'd quit, I think, about 8 or 9 years prior to her presentation. She had been experiencing substernal chest tightness during her exercise routine at the YMCA, about 15 to 20 minutes into her exercise. This was kind of a new complaint for her, worsening over the last 3 weeks, beginning to feel tightness during some household chores as well. Chest tightness was non-radiating, non-pleuritic, relieved by rest, and no associated shortness of breath. Her primary care physician orders an exercise stress echo. The stress echo she did about 7.5 minutes. Bruce protocol achieved around 10 METs, reached stage 3 of Bruce. Rate pressure product 22,400. Exam was terminated due to fatigue. She had normal resting LV function, 60-65%, but at peak stress there was some basal, inferolateral basal inferior hypokinesis. Just to kind of quickly show you the stress images, you can see the inferior basal and inferolateral mildly hypokinetic. So she presents for Cath. Right transradial access, 6 French glide sheath in the radial. My cocktail is just usually 2.5 milligrams of intraarterial verapamil. Sometimes I mix that with 200 of nitro, sometimes I don't. 5,000 units of IV heparin given systemically, intravenously. I did a left heart cath with 5 French pigtail and then coronary angiogram using a JR4 and JL35 5 French diagnostic catheters. So here's her left coronary angiogram. You can see there's a prominent collateralization to what I believe is a posterolateral branch from the right coronary. So now I'm thinking, is this going to be a CTO case, or is this just a really tight stenosis? Obviously expecting something of culprit in the right coronary. To me, the left system looked okay. So then I shoot the right, and this is what I see. Let's see if this next panel plays here. And the right-hand side, of course, is your straight RAO projection, about RAO 30 degrees. And you can see that there is indeed a focal stenosis there in the mid-right coronary, but approximately, I'm concluding this is probably a dissection or multiple dissections. There's also a stenosis distally, right proximal to where you see the continuation of the posterior branch that was collateralized by the circ. So I'm not really, I'm sort of looking at this, and my initial reaction is this. I'm thinking to myself, I've got 4 outpatients today, I've got 2 TEs, I've got to give a fellows talk, and this is my first case, and I'm going to be tied up in this, and I don't even know what is going on here. I've never seen anything like that in the proximal right coronary of any patient that I ever did in fellowship. So I basically sort of looked at this carefully, and I thought, this could be, dissection related to her initial plaque rupture. I don't have any feeling that this was any sort of catheter-related dissection. Thinking, do I want to image this? Is it thrombus? There's a lot of different thoughts going through my mind, and maybe we can talk about this shortly. And I thought to myself, well, this is single vessel coronary disease in a symptomatic indicated patient, so we should percutaneously revascularize her. She was stable. This is, again, an outpatient. This is not an ACS presentation. So this is my equipment, and I'll repeat some of this as I go through the images, but basically I used an AR1 6 French guide, stayed right radial, gave 100 units a kilogram per kilogram of heparin, which is typically what I use for my interventions, rarely used by Valirudin. I did give her Effient 60 milligrams as a loading dose. This is, of course, off-label because this is not an ACS case, and Effient was not studied in these kinds of elective scenarios, but I wanted her to have prompt and potent antiplatelet inhibition, and so I gave her Effient with plans to switch her to Plavix in the future. Initially tried an 014 choice PT floppy wire, which didn't go, and then I did a PT2 moderate support, which you'll see what happened with that. And then these are some of the balloons I used. You can see I used large stents, Resolute Onyx 5.0 stents, and then some peripheral balloons for post-dilatation. Again, all of this will sort of become clear as I go on. So on the left-hand side is the panel with the PT floppy, not really going anywhere. I actually let the interventional fellow kind of have a go at it first, and of course, this is a challenging vessel to wire. On the right-hand side is a PT2 moderate support, which ultimately went. Initially started by ballooning that mid-right stenosis just to sort of clarify my inflow and outflow and kind of get a better look at the vessel. So I ballooned it there, and this is on the right-hand side. You see what we have. You see there is a distal stenosis in that posterolateral branch, but of course, just a lot of disease throughout the proximate and distal right coronary. So I began stenting really distal to proximal, not so much the very distal lesion, but I kind of wanted to take care of the main RCA first and really kind of get some stents there and open up that portion of the vessel, and then maybe get a better look at what was going on in the posterolateral branch. So I stented with Resolute 5.0 stents, Resolute Onyx 5.0, stented the distal, then the proximal, overlapped by about a cell or two along the way, stented the proximal right as well. Was sure to cover the ostium all the way out. And this is what it looks like, and now you can see that kind of outflow stenosis a lot better, which I think was important because I wanted to minimize the length of the stent that I put out there and really be sure that I'm covering that lesion. So then I went ahead and ballooned using, this is actually a 3.5 balloon. Post-dilated my stents and stented in that posterolateral branch as well. Big right coronary. As I mentioned a couple moments ago, I actually used 6.0 peripheral balloons for post-dilating these stents because, of course, the coronary balloons don't come that large. For anyone who's wondering, or maybe you all are already aware, the 5.0 Resolute Onyx stent maximum expansion is 5.75, but I really took it up to high pressure with a 6.0 balloon. I went to like 14 atmospheres, 16 atmospheres, and really wanted to make these stents as large as possible. I chose not to image in this case. I really thought about it. I thought, let me just do a quick IVUS down this vessel, make sure that the stents look good, and that, more importantly, that the stents are accurately overlapped. But I felt comfortable with where I placed the stents. I chose not to image in this case. I think if I could go back and do it again, I probably would have tried to image not only on the front end to confirm that these were dissections or what were these indeed, but also perhaps at the conclusion of the case. But I didn't do that. And then basically that's about it. No perforation, no edge dissections, no residual stenosis. Final result looked good. PDA is small. So TR band to the right wrist, switched her to Plavix with a 600 milligram loading dose the next day. She went home the next day. I kept her overnight after this case. Typically we do same day discharge, but I thought I should watch this one. Guideline-directed medical therapy. At 6-month follow-up, she's doing great. She's returned to her exercise routine. She's completely asymptomatic. So just a couple of the bullet points of this case. Nothing cataclysmic here, but just some basic learning tips that I sort of took away from this. I think it's important to have all your wires and balloons and stent sizes in the room before proceeding. You never know what you're going to get into. A bit of a surprise. This was, I thought, maybe just a focal stenosis to the right, and it ended up showing the right angiogram to look like a complete mess, and not exactly what I expected when I started the case. Hydrophilic wires can be your friend, but they can also be your enemy. If you have a dissected right, or even if it's filled with clot, you can sometimes get underneath something, lift it, and cause further dissection, but I chose to go with one, kept the tip free, got it all the way out there, and it worked out. Choosing your stent sizes carefully, knowing your maximum stent expansion sizes, and being comfortable with using 5.0, 5.5, 6.0 peripheral balloons if necessary for some very large coronary vessels. And then to anticipate the unexpected, just because it's a stable outpatient doesn't mean it's going to be a straightforward case, obviously. So, thank you.
Very good. Excellent result. It looks beautiful. Obviously, you hit on a couple of points that people might wonder about in terms of using a peripheral balloon. Did you need to upsize to an 018 wire for that, or just run it over the 014?
I ran it over the 014, yeah.
And then, how did you decide what the size of the vessel was without imaging?
Yeah. So I just went with kind of my eyeball gut instinct. To me, it looked like it was a 5.5, 6 millimeter right. I looked at the size of my guide, which was, of course, 6 French, so 2 millimeters outer diameter, and I just sort of eyeballed it. And then, of course, I always do a little correction where I just make the stent absolutely as big as I can. As I've progressed over the past year, in my first year on the job, I have used more imaging than I did when I first started. But, you know, I also think to myself, this is a large coronary artery, and I think I made these stents pretty big. I'm not really very worried about the risk of instant restenosis, but of course we want to make sure that the stents are overlapped, that they're well expanded. I thought they looked well expanded, but of course the only way to know would be to image.
Did you think that it could be a scan?
Yeah, that thought crossed my mind. Actually, as we were preparing for the intervention, we had a lot of time to get our equipment ready and to talk about it and look at all the images carefully. There was no rush in this case. And I thought about SCAD. I thought about, you know, did she have a focal stenosis there in the mid-right, and then some sort of dissection plane originated from that and extended proximally because it could not extend distally. A lot of thoughts crossed my mind, but ultimately, you know, she needs to be fixed.
I think some disease in a patient that hemodynamically is not understandable.
Yeah.
You have a scan on your leads.
Right.
I mean, one could submit that. You can
Sure.
just let it go and let the patient be on medical therapy.
Yeah, you know, she's...
do the dissection and then decide what to do.
Yeah, she's in her early 60s, I believe. She did not have any autoimmune diseases, no previous history of, you know, coronary or cardiac disease. The right coronary looked pretty bad to me. It was a big vessel. I didn't feel comfortable with that strategy, but that might have been something one could have tried.
Did you have some concerns about injecting antigrade during all of this? Because, I mean, you have to position your stents and so forth.
Yeah. No, I mean, I actually think that focal stenosis in the mid-right was very protective. Very protective. I mean, I basically approached this case like I was going to own this artery throughout the case and extremely expand these stents as much as I could and just sort of stayed focused and got it done.
Your choice of wire, the choice PT, that's a fairly aggressive, sharp thing.
Yeah.
That is being around for 20, 25 years. And
Right.
You usually don't give it to the fellows because, you know, it's like a monkey with a razor blade.
Yeah.
So,
Yeah. I figured, you know, the vessel's pretty badly dissected already, and the mid-right's focally stenosed, so I thought I'd give him oral.
You can always make it work.
Of course,
So I thought
of course,
that
yeah.
The choice of wire was, I mean, was a little bit aggressive. I mean,
Yeah.
there's nothing to say, and there's nothing with success. So, but
Yeah,
just
no, that's
one
true.
thing
Yeah.
about that choice PT wire, which is not, I think, in one of the armamentarium of the newer modern wires that use for CTOs.
Right.
Can be helpful sometimes, but it's a niche wire.
Yeah, and over the last year, I've had a lot of kind of success with PT2 moderate support wire, Pilot 50 wire. So I've tried those, and they've worked out pretty well. But yeah.
Of course, the other cautionary note is, you know, if you overexpand it too far, you will have a dissection, sometimes retrograde to the
Yeah.
aorta.
Sure.
And so some of us who've all seen that, we're a little, a little hesitant.
Yeah.
I mean, you know, if you get it to 4.0, 5.0,
Yeah.
maybe that's good enough, regardless of what the original size was. And
Yeah.
so I think some of us might have been hesitant to use a 6.0. The other, I think, lesson point that you spoke to as well is image where possible. You know,
Yeah.
in academic medicine, of course, for teaching and sharing.
Sure.
The more we know, the better, the more interesting it is for us. And I struggle with this myself. You know, you're in a busy academic practice. You're always rushing off to the next thing. But if we can at least get some imaging, that can help.
Yeah, absolutely. And over the course of the last year, I've imaged much more. And so I think if the present version of myself had done this case again, I certainly would have. And I've been very surprised oftentimes what I see.
Very good.
Running 5 minutes.
Yeah.
Thank you.